Well, I think we'll go ahead and get started. I want to welcome everybody to week 21 of our Sagis Happy Hour. I wanted to let you know that next week, back by popular demand, Dr. Vickers, Jennifer Vickers, who ran one of our sessions earlier in the year, she's a dermatologist practicing out of Austin, and she's going to be running a session, the theme of which will be cysts. And then a week from this Saturday, for those of you who've registered, we're going to be doing a board review. And so for those of you who are registered for the certification exam, or those of you who have an upcoming Dermpath core exam, I think this will be a good exercise. And we're going to continue rolling these out before each one of the scheduled Dermpath core exams. So if you miss this one, jump on before your next core exam. We'll put them out a few weeks ahead of time. If you have any questions at all today, I'm kind of flying solo. I don't have my support, so please feel free to use the chat for your questions. If I miss them, I'll go ahead and email you. We can track you down by email from the chat. Likewise, you can email me at tdavis@sagisdx.com, or you can post questions to our education email, education@sagisdx.com. My cell phone is 210-416-4815, and I certainly don't mind getting texts or calls if you have any questions or if I can help you out. So with those announcements being said, we'll go ahead and get started. Today's focus is going to be, as I'm sure you know from review of the slides, on external agents. So it's kind of a fun little session. Of course, some of these external agents are introduced into the skin iatrogenically, and some by choice cosmetically. But certainly they're all fodder for board examinations, and especially the iatrogenic items or the cosmetic items. And the testers want you to be able to recognize anything that you might be introducing into the skin. So with that being said, we'll go ahead and get started. Our first case, case one, is an incisional biopsy. And the clues to the fact that this is an incisional biopsy: one, it's fairly large, and two, if you look at the edges, you can see this blue ink here. And generally, when an excisional biopsy specimen comes into the laboratory, before it's breadloafed or sectioned, it will be inked. And so that can be a clue to an excisional biopsy specimen. With respect to anatomic location, we've got a relatively thin dermis and a fair amount of fat here, and a fairly low concentration of follicular and sebaceous elements. So this anatomy, the characteristics of the skin here would be compatible with more distal extremity. Notice too, as we zoom in a little bit, that the surface of the specimen is gently papillated, and we tend to see gentle papillations like that in our flexural surfaces, so elbow, knee, ankle sites such as that. Well, I think as we move into higher power, clearly what catches your eye is the presence of this dark pigment. And you can see that it's confined mainly to the upper half of the reticular dermis, a little bit in the papillary dermis. Let's go down and look at the other piece here as well. It's very, very dark in color. The epidermis, we'll zoom in, is largely unremarkable. We've got a normal cornified layer and an epidermis of normal thickness. And then within the underlying dermis, distributed predominantly in a perivascular distribution, but also some interstitially, is this black, very dark black, and very densely packed pigment that is present largely within tissue macrophages. Now, in a few areas, and I'm going to get my pencil here, you take a look here, you can see a few small particles of this material extracellularly. So it's present both intracellularly and extracellularly. And the granules are a little variable in size and shape, but but clearly dark black. And if you notice, again, it's distributed predominantly around vessels, and there's little, if any, in the way of an inflammatory reaction here. And this, of course, is a tattoo. And of course, tattoos can be either cosmetic or they can be iatrogenic. You know, sometimes the skin is tattooed at the site of a radiation port, or they can be accidental or industrial. But in any of those instances, the lesion forms because there's been mechanical introduction of an insoluble pigment into the dermis. And generally with cosmetic tattoos, the pigment granules are all about the same size, and the idea is to introduce them into the dermis, of course, at the same depth so that one gets uniform pigmentation. That, of course, gives one the best cosmetic effect if the tattoo is decorative or cosmetic. When a tattoo is accidental or industrial, what you see a lot of times is deeper implantation of the pigment into the reticular dermis. Not only that, the pigment that's introduced is not as uniform as this. The granules tend to vary in size, and they can also vary quite a bit in shape. So this is a tattoo pigment or a tattoo, not really even a reaction, just tattoo in the skin. And over the last several years, we've noticed fewer complications in the skin from tattoos. I think owing to a couple of reasons. One, there's been a tendency for professional tattooers to get away from using some of the mercuric or mercury-based red colors to more different materials to produce the red color. And as a result, the allergic and hypersensitivity reactions have declined somewhat. In addition, there's tighter regulation of tattoo parlors, and so the incidence of infectious processes has kind of diminished over the years. But anyway, classic tattoo. The take-home points here are one, there typically is not much of a host response. Two, in the case of professional tattoos, the pigment's pretty much all at about the same level. And number three, and I think critical to making the diagnosis, is you tend to get deposition of that pigment both intracellularly and extracellularly. So let's go ahead and move on to slide 2. And slide 2, we have a bisected punch biopsy. Let me go ahead and tilt this around. And one can see the cornified layer is markedly thickened by compact orthokeratosis. If we look at the top biopsy, we see the epidermis is mildly hyperplastic. There are no follicular structures here in the dermis consistent with volar or particularly an acral site. And within the upper portion of the dermis, we actually have a large abscess here. So we've got a collection of neutrophils within the dermis, and it's surrounded in part by granulomatous inflammation. You can see multinucleated epithelial histiocytes. So we've got suppurative and granulomatous inflammation. And of course, when we see suppurative and granulomatous inflammation, we think about infectious processes. In fact, the most common cause of suppurative and granulomatous dermatitis in the skin is ruptured follicle or ruptured cyst. But, you always want to be cognizant of the fact that it's a reaction pattern seen with infectious organisms. So if that's a possibility, you want to make sure you carefully analyze the sections. If we look at the bottom piece, however, in the middle of the abscess, we see this brown material here, kind of light tan or golden brown, really, in the center of the abscess. And moving down to higher power, we can see that this material has very thick cell walls, and the cells have kind of a honeycomb pattern. And this, of course, is very characteristic of plant or vegetable material. This, of course, is a splinter, and it frequently induces a fairly brisk inflammatory response, as any of you know who've had a splinter. When we do see a splinter introduced into the skin like this, it's always a good idea to carefully examine the splinter. And what we look for at times is the presence of domitiaceous or pigmented fungi or colonies of bacteria, because this is a common mode for implantation of those organisms into the skin. In the case of a domitiaceous fungus, this is how I think a lot of phagohyphomycotic cysts form, or you can set up a deep cellulitis or bacterial infection if there are pathogenic bacteria in the plant material as well. So if we'll carefully examine the plant material here, there were no organisms that I could see. If there's any doubt, I'll go ahead and state them. And again, I'll make mention of them in the report. Not that anything needs to be done. It's just good to note in case after removal of the plant material, the patient has a persistent eruption or develops an enlarging tender nodule or abscess in that area, and then you know kind of what you might be looking for. So this appearance, thick cell walls, and kind of this honeycomb pattern of the cells is very characteristic of plant material. And this, a lot of times, this plant material is doubly refractile when examined with polarized light. We'll go ahead and move on to slide 3. 3, 4, and 5 kind of are dealing with similar response, similar condition, similar iatrogenic agents, I should say. And in this particular specimen, we have an incisional biopsy. This is from the trunk or proximal extremity. We've got a fairly low concentration of follicular and sebaceous elements and a fairly thick dermis. The epidermis is kind of thinned with effacement of the reedy ridge pattern, and we have this little depression in the epidermis. And if we go down and take a look at the papillary dermis, we can again see effacement of the reedy ridge pattern. We've got a few vertically oriented vessels here. And then if we go down and look in the underlying dermis, we begin to see these histiocytes containing this kind of blue-gray granular material. And I think it was easier to see in some foci. In addition, we've got some calcium deposition within the dermis, and especially encrusting some of the collagen fibers. So let's go up to the top piece and take a look up here. And again, you can see effacement of the reedy ridge pattern, a little depression in the epidermis, and a zone of papillary dermal fibrosis or fibrosing granulation tissue. I think we can see these histiocytes, I'm going to get the pencil again, containing this granular blue-gray material in better detail in this particular section. So what we've got here is a biopsy site. A previous biopsy was done here. We've got some fibrosis or fibrosing granulation tissue, and the dermis is going to give rise to a very superficial scar. And this material in the histiocytes in the underlying dermis is aluminum chloride or Drysol, which was used as a hemostatic agent. And the calcification in the dermis is a frequent accompaniment to an aluminum chloride reaction. And this is kind of an important thing to note. One, you want to make sure that you don't misread those as parasitized histiocytes and raise the possibility of histo or some type of infectious process. And two, anytime we look at a re-excisional specimen of something, we as dermatopathologists always look to make sure that we can identify the biopsy site. As you know, sometimes patients with sun-damaged skin or very weathered skin heal extremely well. And if, say, a photograph wasn't taken or the orientation or site are not real clear or the patient can't remember, it can be very, very difficult. And at least once or twice a year, I'll have to have the very uncomfortable discussion with the clinician, calling them and saying, hey, I've leveled the section, I've looked at multiple sections, and I can't see the biopsy site. Are you sure that you did the re-excision at the right site? So the presence of scar, fibrosing granulation tissue, and again, the presence of aluminum chloride can be a useful clue to the site of prior procedure. And you want to make sure you recognize this. There's really not much of a brisk host response, and this certainly will not tattoo the skin like Monsel solution. So there was a shift a number of years ago from routine use of Monsels or ferric subsulfate to aluminum chloride for hemostasis. Okay, let's go ahead and move on to slide 4. Okay, and with slide 4, let me tilt the slide here. Again, inked specimen. So we've got a little excisional biopsy specimen here. And this is clearly from sun-hammered skin. This particular biopsy was from the shoulder right up by the neck. And one can see, and I'm going to use my pen here, this broad solar elastotic band within the dermis here. It's kind of rotating, sorry about that, or moving. So you can see this big solar elastotic band within the dermis. And the papillary dermis is markedly expanded here. And you can see it's kind of depressing or pushing down the solar elastotic band. If you take a look at this zone, you can see there's no adnexal structures. There is fibrosis, an increased number of fibroblasts and dilated vessels. And again, this is another biopsy site. But unlike the last specimen we took a look at, beneath or at the base of the previous biopsy site, one can see numerous pigment-laden macrophages. And these macrophages contain within their cytoplasm these granules, but the granules are not uniform in size. Some are big and chunky, and some are quite small. And if you had a fine focus on your microscope, you could see that these were actually refractile. And then out of the periphery, there are actually a few multinucleated histiocytes and fibroblasts as well. And this is Monsel solution, or Monsel's tattoo, Monsel's reaction. Monsel's solution, of course, is ferric subsulfate. That's a 20% solution of aqueous ferric subsulfate. And one gets the presence of siderophages within the dermis as a result. You can also get ferrugination of the collagen bundles, and it can induce a pretty brisk inflammatory response with histiocytes, multinucleated histiocytes. It can almost even produce a pseudosarcomatous reaction. And in re-excisions, let's say, of an atypical fibroxanthoma or some type of sarcoma, if Monsel's has been used, sometimes it can be difficult to distinguish this reactive proliferation due to Monsel's from residual tumor. And so it can be a little bit problematic. That being said, it's an excellent hemostatic agent. I think in many instances it actually works better than aluminum chloride, but because of its tendency to produce more of an inflammatory response and to tattoo the skin, it's not used quite as often. And you can imagine, because this is an iron-containing compound, it will light up like a Christmas tree. If you threw a pearls or other iron stain on it, it would stain very, very bright blue. So this is Monsel's, and I would definitely familiarize yourself with what Monsel's and aluminum chloride look like under the microscope. So our fifth case is the last in our trio of agents that are used to help stop bleeding in biopsies. And we've got here a punch biopsy. This is again from a volar surface. There's compact orthokeratosis and a little bit of epidermal hyperplasia, fair amount of fat here, and some eccrine coils, but no hair follicles. And then in the central portion of the specimen, right below the papillary dermis, one can see these kind of irregularly shaped blue, purple, almost arabesque net-like structures. And they are surrounded at the periphery by granulomatous inflammation. And this is gel foam, and a very characteristic appearance gel foam does. It almost looks a little like a pterodactyl or like jellyfish, like some type of alien structure here. Very distinctive appearance. This particular hyperplastic epithelial structure is not a follicle. If you take a look in the center, you can see a little duct here, and this is hyperplasia deriving from acrosyringeal epithelium, and it's the body's attempt to form a transepidermal elimination channel to get rid of this gel foam. Usually, of course, it's resorbed by the time you would get transepidermal elimination. And then we've got fibrosing granulation tissue. This was undoubtedly a punch biopsy site. So we've looked at 3 hemostatic agents: aluminum chloride, which is characterized by the blue-gray granules in the cytoplasm, not much of an inflammatory infiltrate, and a little calcium deposition. We've looked at Monsel solution, in which you do quite a bit of fibrosis, and within and beneath the zones of fibrosing granulation tissue, pigment-laden macrophages containing kind of brownish to refractile granules that vary in size. Some of them are quite chunky. And then we've looked at gel foam, which is characterized by these irregular arabesque-shaped kind of blue-purple structures that form like a net-like pattern and are surrounded by granulomatous inflammation. And again, I would be familiar with this because you're likely to be testing on materials that you're going to be implanting into the skin. Okay, let's go ahead and move on to slide 6. This is a good teaching slide for a number of reasons. And you can see we actually have 6 pieces of tissue here. And this was actually a deep shave that was done from the ear. And, you know, it's a lot to look at on scan, but one key teaching point in dermatopathology is you always want to see how many pieces of tissue you have so that you don't miss them. The piece that has the action in it. And it also gives you an idea of kind of the lay of the land. And, you know, in this particular biopsy specimen, what really should catch your eye is at the base of this piece of tissue. You know, we've got this large collection of amorphous materials. So, you know, you want to make a mental note to go back and take a look at that. But looking at the other pieces first, again, one can see that the dermis here is a little bit fibrotic, and there are vertically oriented vessels, and there are no adnexal structures here, and slightly thickened collagen bundles. And we kind of see that in all of the pieces here. And we've kind of got these fascicles of thickened collagen bundles forming whorls associated with an increased number of fibroblasts and absent adnexae and dilated vessels. And what we have here is a hypertrophic scar. And then if we take a look at this piece, let me go ahead and get rid of that diagram there. What you see is we have these large accumulations, almost lakes, of this kind of bubbly, feathery, amorphous, somewhat granular pink to blue material. And this is intralesional Kenalog, or intralesional steroid, which was injected into a hypertrophic scar. And you can see out of the periphery, there's no host immune response, which is a good thing. That's why we inject the intralesional Kenalog. Occasionally, you can see a few epithelioid histiocytes, but generally, there's not much in the way of an inflammatory response. Sometimes, if this material is not so bubbly and real amorphous, it can resemble mucin. You can always do a mucin scan, but mucin will never have this bubbly appearance. And so this is very characteristic of intralesional Kenalog or steroid. Usually, if we see it in tissue, it's going to be in the setting of a hypertrophic scar or keloid. Occasionally, you can see it in lesions of AA, alopecia areata, kind of down deep. And rarely, it has to be kind of a situation where someone's getting repeated steroid injections from time to time. I've seen it in the buttock region above a zone of lipoatrophy. And so, the patient will come in with a depression. A biopsy is not to confirm lipoatrophy. And sometimes you can see a little bit of residual steroid in that setting. But this is a very characteristic appearance of intralesional catalog, and I'd definitely be able to recognize that as well. Okay, let's go ahead and move on to slide 7. Slide 7, we have a trisected punch biopsy. This is from the face. We've got a fair number of sebaceous glands here. I think what really catches your eye is, all this clear staining material on the dermis. And so the question is, is this intracellular? Is this extracellular? Is this some type of clear cell metaplasm? Well, as we move into higher power, what we see is actually filling the dermis. We've got these vacuoles, and these are clear staining vacuoles that are markedly vary in size and shape. And most of them are empty. As a matter of fact, all of them are empty. You can't really see material in them. You see these clusters of vacuoles that are variable in size and shape. Some are tiny, some are big. There's maybe a little thickening of the collagen around it, and there are a few macrophages or histiocytes in the intervening dermis. And this is a very characteristic appearance for silicone. And of course, silicone is can be injected in a variety of locations for tissue augmentation. Occasionally, we'll see leaking breast implants, and the silica will leak out into the dermis and have an appearance very, very similar. But these variably sized vacuoles surrounded by macrophages, and at times fibrosis, are very, very characteristic of silicone, and generally doesn't produce too much of an inflammatory response. Some people can be very sensitive, and occasionally you can get more of an inflammatory response of granulomatous inflammation, but this appearance is very characteristic of silicone. Okay, let's go ahead and move on to our next case. Case number 8. Case number 8, I'm going to go ahead and flip it, is a punch biopsy. And in this particular instance, if we try to discern location, we've got stratified squamous epithelium. As we move to higher power, you can see there's parakeratosis. There's really no granular layer, so we kind of get this abrupt keratinization with no interposition of a granular layer. Got a few dilated vessels within the underlying lamina propria, and we've got all this skeletal muscle down here in the dermis or lamina propria as well. And this is from the labial, the oral mucosa, the labial mucosa with the skeletal muscle and mucosal epithelium. And then obviously what catches your eye in the dermis is extensive granulomatous inflammation. And the granulomatous inflammation is surrounding these round, kind of brownish gray spherules. Sometimes this material can be more blue-gray than brown-gray, and it can also be calcific. And this appearance with these microspherules surrounded by granulomatous inflammation is very characteristic of calcium hydroxylapatite or Radiesse. It's non-birefringent, and in this particular instance, the material was injected into the nasolabial fold, and Radiesse will occasionally migrate, and it migrated into the mucosal surface of the lip, and the patient had a nodule there. So they went ahead and did a biopsy, but these spherules that are either gray-brown or gray-blue and calcific are very characteristic of Radiesse. And you want to make sure that you can identify the key classic fillers, because you're going to be tested on that. The other thing to note too, I just happened to notice it at this time. Do you see the way that there are rips, vertical rips in the tissue? That's particularly common with foreign bodies. And what happens is when the tissue gets mounted onto the chuck, onto the microtome, when the blade hits the foreign material, it tends to rip and drag through the dermis, producing these rips in the tissue. So rips in the tissue can be a clue to foreign body reaction. Okay, let's go ahead and move on to slide 9. And slide 9 is a pretty doggone deep biopsy. We move to higher power. You can see there's actually no epidermis here. We have a lot of skeletal muscle, and skeletal muscle, you remember from medical school, is striated, and so sometimes you can see the striations. And it's also multinucleated, and you'll remember with skeletal muscle, the nuclei tend to localize out at the periphery of the cell. So this is skeletal muscle, and we have a little bit of fat here. So we're fairly deep. And then we've got this big nodule here of histiocytes, most of them multinucleated. So we've got a big granuloma. And within the central portion of the histiocytes, we kind of have this translucent particulate material that has kind of a spiky appearance. And again, normal fibrosis, multinucleated histiocytes, and this kind of translucent, irregularly shaped, spiky material within the cytoplasm. And this type of reaction is very characteristic, or this histologic appearance is very characteristic of poly-L-lactic acid, or Neufil or Sculptra. And the one thing that it can mimic histologically is a keratin granuloma. Occasionally, if you see rupture of a follicle or rupture of a cyst, you get this massive accumulation of epithelioid histiocytes. But within the cytoplasm of the histiocytes, in that case, you see cornified cells or keratin, rather than this translucent, irregularly shaped material. I'm going to get my pencil here, kind of outline a piece of this material here. You can see it's, almost looks glass-like. It certainly does not look like keratin. So this is Sculptra or Neufil poly-L-lactic acid. It's a very, very common appearance. Okay, let's go ahead and move on to slide 10. Slide 10, let me tilt it a little bit. We've got a punch biopsy. And again, we can get an idea here that we're on base or neck. We've got skeletal muscle, and really on the head and neck, face and neck is the only place that skeletal muscle inserts into the dermis. We don't have a high concentration of follicular or sebaceous elements here. We do have solar elastosis. So this particular biopsy was on the neck. And what jumps out at you are these pools of kind of amorphous light blue material, lakes of light blue material with no associated host response. And this histologic appearance is very characteristic of Restylane or Juvederm or Perlane. It's hyaluronic acid. And the accumulations of the material tend to vary not only in size, but also in shape. And typically with the older products, you don't get any host immune response. With some of the newer cross-linked hyaluronic acid products, they can be a little bit more immunogenic, and so you're more likely to see a little bit of granulomatous inflammation. And of course, this is resorptive material. Most of the times when we see hyaluronic acid in the skin, it's secondary. So a lot of times, you'll see an excision of a basal cell or, biopsy of a rash, and there's pooled hyaluronic acid at the base of the specimen. And, usually if you call the clinician, they'll say, oh, yeah, the patient had Restylane. So in most instances, it seems to be an incidental finding. Okay, let's go ahead and move on to 11. 11 and 12 are a little bit different. Slide 11 was very, very subtle. And we have a punch biopsy here. And we've got a terminal hair follicle here embedded down in the fat. And so, one could think about the possibility of scalp or bearded area of a male. And this was actually from the chin of a male, cheek near the chin. And we take a look at it, the epidermis and cornified layer are pretty unremarkable. There may be a slight increase in the amount of melanin within basilar keratinocytes. Within the dermis, there's really not much of an inflammatory infiltrate, perivascular infiltrate of lymphocytes, maybe a few dilated vessels, but there's certainly not a whole lot going on here. But if we go down and look at the sweat gland coil, we can see both glands and ducts. And you look carefully, I can't go down any higher power, but what we see here are tiny little black particles, and they're kind of lined up and outlining the basement membrane of the sweat glands. And this is a very characteristic finding in cases of Argyria. And so if you see Argyria on the pick list of a test, or if you're thinking about it, you want to make sure you hone in on the basal lamina of the sweat glands. Occasionally, you can also see the material in the basal lamina vessels. I didn't see it in this particular biopsy specimen, and rarely it will start to deposit on elastic fibers in the skin. But mainly, you're going to see it around the eccrine coils, and it's a very pauci-inflammatory condition. So it really enters into that differential of nil diagnosis or normal skin diagnosis. And so, if you don't see much going on, you can start in the stratum corneum and work your way down through the epidermis to the basal layer and into the dermis. And one of the things you always want to look for in that setting, if you've got no history, is to go ahead and look around the sweat gland coils. I appreciate you guys monitoring the chat for me. I'm sorry, I'm not real good at multitasking, so thanks for answering each other's questions. So this is very characteristic, again, of Argyria. And of course, Argyria can result from dietary ingestion of the silver or medicinal or occasionally industrial exposure to silver-containing agents. And it produces, of course, this characteristic blue-gray slate pigmentation that can be photodistributed. You can also get localized Argyria if the silver is applied topically, or if it's dramatically implanted in the skin. And the last case of Argyria saw, it was a really sad case, 15-year-old woman, a young woman, and she had ordered some supplement online that contained silver in it, and took it for a few months and ended up with just like, she looked like a Smurf, blue-gray skin. It was just really, really sad. And of course, they hadn't indicated online that the material had silver in it. Okay, let's go ahead and move on to our last slide, slide 12. Skinny little biopsy here. Let me flip it. And again, we take a look at the epithelium here. We see that we've got parakeratosis, no granular layer, kind of an edematous and vascular dermis. And this again was a mucosal surface. This was oral mucosa. And hopefully you noticed right away within the dermis, kind of these yellow to yellow-brown to kind of dark brown linear structures and black fragments and granules that were present free in the dermis or in many instances kind of deposited on these fibers, these connective tissue fibers in the dermis. And they're present very, very deep in the tissue all over the place. And this is an amalgam tattoo. And the linearity of these structures, these golden brown to dark brown to black granules deposited in a linear fashion on the connective tissue fibers and also present free in the dermis is very characteristic of an amalgam tattoo. The amalgam, of course, is a kind of a mixture of silver, mercury, and tin. And these tend to follow a traumatic dental procedure. And they typically occur on the buccal, the gingival, the alveolar mucosa, and typically the patients present with these gray macules. Very characteristic appearance for an amalgam tattoo. I think it bears some similarity to the size of granules and the color to what you see in Argyria, but rather than being deposited in the basement membrane, it's going to be present fibers in the dermis. So this is kind of a fun session, but it's kind of high yield and good to recognize these materials and structures. And I'm sure most of you know in the back of Elston in an appendix, he's got a whole little section there on external agents. And he also covers as well, I would take a look at that cautery artifact. But anyway, I appreciate you guys minding the chat. And if anybody has any questions, please feel free to reach out to me via phone or email. And I hope everybody has a wonderful evening and tune in next week. Thank you very much.